Welcome back to the deep dive. Today we are shifting gears pretty significantly where we're dropping the usual observer persona and we are stepping right into the fire. I want you to imagine we're standing just outside the exam hall at Gujarat University. You're the candidate, the postgraduate student, about to face the music, and I'm your study partner. But we aren't alone. We've brought in the heavy artillery. We are simulating a really high-stakes prep session for the MD anesthesiology exams, focusing on a topic that, well, it literally determines whether a patient lives or dies on the table.
It's good to be here. And honestly, you're right to set the stakes that high. Today isn't just about, passing a theory paper. It's about understanding the very engine of anesthesia. We're tackling ventilation, perfusion, mismatch, and dead space.
The dreaded VQ ratio.
The absolute bread and butter of our specialty. Look, if you can't explain why a patient desaturates during induction or why the CO2 gap widens in the ICU, you're not just going to fail the Viva, you're going to struggle in the operating theater. This is the core physiology that dictates safe practice.
So the mission for this deep dive is crystal clear. We need to construct a bulletproof 10 to 20 mark answer for the theory paper. And we need to prep you, the listener, for those tricky Viva questions where the examiner, tries to lead you down the garden path.
Exactly.
We've got the whole stack here, Miller, Morgan, Guyton for the pure physiology, plus the Oxford Handbook and ICU protocols for the clinical side of things.
And we're synthesizing it all. We have to. We need to bridge that gap between the textbook graph, which can feel very, very abstract, and the patient on the table who is turning blue, which is very concrete.
Okay, let's jump right in. Part A, introduction and exam framing. If I'm sitting in that exam hall sweating a bit, and I see a question on VQ, mismatch, or dead space, how do I start? What's the core concept I need to get down on paper immediately to show I know what I'm talking about?
You have to start with the fundamental goal of the lung. The lung has one job and one job only: gas exchange. But for that to happen efficiently, you need what I call a perfect marriage. You need fresh air, that's ventilation, and fresh blood, that's perfusion, to meet at the exact same place at the exact same time.
Right.
It's not enough to just have air somewhere in the lungs and blood somewhere in the vessels. They have to be physically paired right across that alveolar capillary membrane.
So it's basically a logistics problem. If the ventilation shows up at the restaurant, but the perfusion goes to the movie theater, nothing happens.
Precisely. That's a mismatch. And the reason this is so critical for us, for anesthetists, and why the examiners are obsessed with it, is that our entire practice inherently disrupts this marriage.
How so?
Well, think about it. The moment you induce anesthesia, you often cause some atelectasis. The lungs collapse a bit at the bases. That affects the matching. Then you turn on a ventilator and start pushing in positive pressure. You're squeezing capillaries. That affects the matching. Miller states it very clearly. VQ mismatch is the single most common cause of hypoxemia in the perioperative period.
So if an examiner asks me, why is your patient hypoxic? My first and best guess statistically should be VQ mismatch.
It's the highest yield answer, without a doubt. In the exam, you'll see this come up in a couple of ways. You might get a long question, something like, describe the VQ ratio and its variations in the upright lung. That's a solid 10, maybe 20 mark question. It needs a structured SO.
Need 2 more notes.
Things like physiological dead space or the Shunt equation or West zones.
And the Viva. I feel like that's where people really trip up.
The Viva is where they set the traps. A classic examiner favorite, an absolute classic, is asking, does giving oxygen treat all forms of hypoxemia? If you just reflexively say yes, well, you've walked right into their trap.
I see.
You have to understand the fundamental physiological difference between a VQ mismatch and a true shunt to answer that correctly.
Okay, we will definitely get to that distinction. I know that's a huge stumbling block. But before we get into the pathology, let's solidify the normal. Let's move to part B, the VQ ratio itself. If I'm writing that definition for the exam, what are the magic words, the key numbers I need to use?
You have to stick to the safe standard exam definitions. First, ventilation. And specifically, we're not just talking about any ventilation. We're talking about alveolar ventilation. V with a subscript A. Ideally, this is around 4 liters per minute.
Okay, can we just clarify that for a second? Why alveolar ventilation and not just minute ventilation?
That's a great question, and it's a distinction that gets you marks. Minute ventilation is the total amount of air you breathe in a minute. But that includes all the air that just sits in your windpipe, your trachea, your bronchi. We call that dead space. That air doesn't do anything.
It never sees the blood.
It never sees the blood. The blood only cares about the air that actually reaches the alveoli, the little air sacs where the action happens. So if your minute ventilation is, say, 6 liters, but 2 liters of that is just wasted in the airways, Your alveolar ventilation is 4 liters. That's the number that matters.
Okay, so 4 liters of useful air. And what about the blood side?
The blood side is perfusion, which we call Q. It's essentially the cardiac output that's flowing through the pulmonary capillaries. Ideally, that's about 5 liters per minute in a normal adult.
So we do the math. V divided by Q, 4 divided by 5.
And you get the golden number, 0.8. You must state this clearly for the examiner. The global VQ ratio is 0.8. But, and this is the little bit of expert insight that shows you really understand it, you must immediately clarify that this is just an average, a global figure. In reality, the lung is a massive, messy spectrum of different ratios.
Right, it's an average of extremes. It's like if one person has $1 billion and I have 0, on average we're both semi-billionaires, but the reality is very different.
That's a very accurate, if slightly depressing, analogy for how the lung works. And this brings us straight to the regional variation of the VQ ratio, which is absolute gold for the exam.
Yeah.
You have to understand how gravity messes with the upright lung. This is where you might reference the rib number distribution you see in textbooks like Guyton.
Okay, let's break it down. Top of the lung, the apex versus the bottom of the lung, the base. What's physically happening?
Gravity pulls everything down. The lung tissue itself has weight. I want you to imagine holding a slinky spring from the top. The coils at the top are stretched wide apart, right? They're holding up the weight of all the coils below them.
True.
And the coils at the bottom are all crushed together.
Okay, and the lung tissue acts like that slinky.
Exactly like that. Because of the weight of the lung, the intrapleural pressure, that vacuum that keeps the lungs from collapsing, is more negative at the apex at the top than it is at the base. So at the apex, the alveoli are already stretched open. They're like large, distended balloons even before you take a breath.
So if they're already pretty full, they can't take in much more air when you breathe in.
Precisely. They have low compliance. They're stiff. So when you take a breath, they don't expand much more. Ventilation at the apex is actually quite poor compared to the base.
Okay, so the top is poorly ventilated. What about the bottom, the base?
At the base, the alveoli are kind of squashed by the weight of the lung tissue above them. They start out small. But because they're small, they're on the really steep compliant part of that pressure volume curve. They are primed and ready to expand. So when you breathe in, the base gets the vast majority of the fresh air.
So ventilation increases as you go from the apex to the base.
Correct. Now let's look at perfusion. Blood. Blood is a fluid. It's heavy. Gravity pulls blood to the bottom of the lung much more aggressively than it affects air. The hydrostatic pressure at the base is way higher than at the apex. So perfusion also increases from apex to base.
So both ventilation and perfusion increase as you go down the lung.
Yes, but, and here's the crucial distinction you must make for the exam. Perfusion increases more than ventilation. The slope of the blood flow gradient is much, much steeper than the ventilation gradient.
Because blood is just heavier than air.
Effectively, yes. That's a good way to think about it. So the relationship, the ratio, changes. Let's look at the apex again. At the apex, you have low ventilation, but you have terrible perfusion. The blood just can't pump up that high against gravity very well. So relative to the tiny amount of blood that makes it up there, you actually have extra air. Ventilation, V, is greater than perfusion, Q. The ratio is greater than 1. In fact, it can be as high as 3.0.
And what does that mean physiologically for the gases?
It means you have wasted ventilation. We call this dead space-like. The oxygen tension, the PO2, is really high, over 130 millimeters of mercury, because there's no blood there to take the oxygen away. And the CO2 is low because there's no blood delivering CO2 to be removed.
Okay, now take me to the base.
At the base, it's the opposite story. You have great ventilation, but you have massive perfusion. The area is just flooded with blood. So perfusion Q is greater than ventilation V. The ratio drops below 1, often to around 0.6.
And this is what we call shunt-like.
Exactly. There's too much blood for the available air to fully oxygenate. So the oxygen levels in the blood leaving the base are lower, and the CO2 levels are a bit higher. This regional variation is critical. When a patient is upright, the apex is functional dead space and the base is functional shunt. That 0.8 is just the mathematical average of this whole physiological mess.
And this must have huge anesthetic relevance, right? When we change the patient's position, like putting them on their side for thoracic surgery.
It's huge relevance, absolutely massive. Kaushik's textbook highlights this beautifully. Think about an awake patient lying on their side. Gravity pulls blood down to the dependent lung, the one on the bottom. But because their diaphragm is working normally, the bottom lung also gets the best ventilation. So V and Q are pretty well matched.
You're smart.
Nature is very smart. But then we come along and anesthetize them. We paralyze their diaphragm and we put them on a positive pressure ventilator. Now, the diaphragm becomes just a floppy sheet. The weight of the abdominal contents pushes up against that bottom lung, squashing it. It becomes really hard to ventilate. So the gas, the air, it all goes to the path of least resistance, which is the non-dependent, the top lung.
But gravity is still pulling all the blood down to the bottom lung.
Exactly. So now you have a situation where the air is going up to the top lung, which has very little blood, and all the blood is going down to the bottom lung, which is getting very little air. It's a total mismatch. You've created a massive physiological problem just with induction and positioning. That is why understanding VQ ratios isn't academic. It explains why your patient's saturation plummets during one lung ventilation.
Okay, this is a perfect segue. Let's move into Part C, VQ mismatch itself. This is the core of the pathology. We've defined the normal, now let's break down the abnormal.
Right. For the examiner, you want a crisp definition. Define VQ mismatch as any deviation from the ideal one-to-one matching of ventilation and perfusion, and you must explain that it's a spectrum.
Walk me through that spectrum.
Imagine a line. On the far, far left, you have a VQ of 0. That means 0 ventilation, but you still have perfusion. That is a true shunt. As you move a little to the right, you get a VQ that's less than 1. That's a low VQ unit, or what we call relative shunt. Then you pass the ideal value, you get to a VQ greater than 1. That's a high VQ unit, or relative dead space. And on the far, far right, you have a VQ of infinity. That means you have ventilation, but 0 perfusion. That is true dead space.
Okay, so let's drill down on the left side of that spectrum, low VQ ratio. The shunt-like states. Our notes say this is very high yield.
It is extremely high yield because, as we said, it's the most common cause of hypoxemia we see in the OT and the ICU. Pathophysiologically, what's happening is you have alveoli that are open, but they are underventilated relative to the amount of blood flowing past them.
So deoxygenated venous blood is passing by, but it's not getting fully topped up with oxygen.
Correct. It then goes and mixes with all the well-oxygenated blood from other parts of the lung. It essentially dilutes the clean arterial blood, and that's what lowers the overall arterial PO2. We call this phenomenon venous admixture.
What causes this? I need a good surgical sieve for the exam, a way to categorize the causes.
The best way is to think airway, alveolar, and mechanical. For airway causes, think of things that block airflow. Mucus plugs, a foreign body, bronchospasm. For alveolar causes, think of things filling the air sacs. Pneumonia, pulmonary edema, and the big one for us, atelectasis. Very, very common post-induction. And for mechanical causes, the classic example is an endobronchial intubation, where you've accidentally put the tube down one bronchus, effectively creating a massive one-lung ventilation scenario.
Okay, now for the million-dollar Viva question we teased earlier. How does a low VQ mismatch respond to giving the patient more oxygen?
It responds, this is the crucial example you cannot forget. Low VQ does respond to an increased FiO2.
And why is that?
Because the alveoli are still open. They're just poorly ventilated. If you flood the entire lung with 100% oxygen, even that tiny amount of ventilation that's getting into that sick unit is now carrying a huge partial pressure of oxygen. The gradient for oxygen to move from the alveolus into the blood becomes massive, and it forces oxygen across. This is what distinguishes it from a true shunt.
And the body has its own way of dealing with this, right? The lung doesn't just sit there and accept this mismatch.
Right. That's hypoxic pulmonary vasoconstriction, or HPV.
Right.
It's a beautiful, elegant reflex. If an area of the lung becomes hypoxic, the pulmonary blood vessels in that specific area constrict. They clamp down.
They're trying to divert the blood flow to a better neighborhood where there's more oxygen.
Exactly. It's an auto-regulatory mechanism that shunts fluid away from the bad alveoli and toward the well-ventilated ones, all in an effort to preserve the VQ matching as best it can. But, and here is the anesthesia trap, our volatile anesthetic agents, especially at high concentrations, typically anything over 1 MAC, can inhibit HPV.
So let me get this straight. We anesthetize the patient, which causes atelectasis, creating the low VQ unit. And then the very drugs we're using stop the body from being able to fix the problem we just created.
Precisely. You worsen the mismatch. Miller and Morgan both emphasize this point very heavily.
Okay, let's flip the coin. Let's talk about high VQ ratio, the dead space-like states.
Here, the problem is wasted ventilation. Air is dutifully entering the alveoli, but there's little or no blood flowing past to take the oxygen away or drop off CO2.
And the causes for this?
Think vascular first. The absolute classic exam answer is a pulmonary embolism, a PE. A clot lodges in a pulmonary artery and stops blood flow. The alveolus downstream is full of fresh air, but no blood ever sees it. Then think cardiac causes. Low cardiac output states like severe hypovolemia or cardiogenic shock. The blood pressure is so low it just can't perfuse the upper parts of the lungs against gravity. And finally, iatrogenic causes. Things we do. The main one is high PEEP.
Wait, high PEEP can cause dead space. I thought PEEP was supposed to help oxygenation.
It is, but it's a double-edged sword. If you apply too much PEEP, you can overdistend an alveolus. The pressure inside that air sac can become higher than the pressure in the delicate capillary running over its surface. You literally squash the capillary flat. You've just turned a functional lung unit into West Zone 1. You've created dead space.
So what's the primary clinical effect here? Is it hypoxia?
Not primarily. The main effect is impaired CO2 elimination. You get hypercarbia. Because the ventilated air isn't meeting any blood, it can't pick up the CO2 that needs to be exhaled. This leads to a rise in the gradient between the CO2 in your blood, the arterial CO2, and the CO2 you measure at the end of your breath, the end tidal CO2.
Right, we'll definitely circle back to that gradient when we talk about measuring dead space. But first, we absolutely need to solidify the difference between a true shunt and a VQ mismatch. This is the exam favorite comparison.
It is. It's often a table question on the theory paper or a direct Viva question. So, shunt or true shunt, VQ is 0. Perfusion without any ventilation. Examples are intracardiac shunts like an ASD or VSD or complete alveolar collapse, massive atelectasis. The crucial feature, it does not respond significantly to 100% oxygen. The shunted blood never, ever sees the air, no matter how much oxygen you put in it.
Okay, and the VQ mismatch side of the table.
VQ mismatch, specifically a low VQ. The VQ is less than 1. It's poor ventilation, not zero ventilation. And the crucial feature here, it does respond to 100% oxygen because there is still some air getting in.
There's an equation for this, isn't there? The shunt equation. Looks a bit intimidating.
The shunt equation, which calculates the shunt fraction, Qs over QT, it does look intimidating, but you just have to memorize it. It's non-negotiable for the exam. It's the oxygen content of capillary blood minus the oxygen content of arterial blood, all divided by the oxygen content of capillary blood minus the oxygen content of mixed venous blood.
Okay, let's try the mnemonic from the outline. Captain arterial over captain venous.
That works perfectly. The numerator is capillary minus arterial. The denominator is capillary minus venous. CCO2 is the ideal capillary oxygen content, what it would be if it were perfectly oxygenated. CO2 is the actual arterial oxygen content you measure from an ABG. And CVO2 is the mixed venous oxygen content, which you'd get from a pulmonary artery catheter or a central line.
In a perfect world, the shunt fraction should be 0, right?
In a perfect world, yes. But physiologically, there's always a small shunt. The normal value is less than 5%.
Now, why isn't it 0 in a healthy person?
Because of two main sources. The Thebesian veins, which drain the heart muscle itself, and the bronchial veins, which supply the airways. They both dump deoxygenated venous blood directly into the left side of the heart, into the arterial circulation, completely bypassing the lungs. That's our normal physiological shunt.
So the clinical take-home is, if I have a patient on 100% oxygen and their PO2 just isn't rising, I have to stop thinking, oh, it's just a bit of mismatch, and start thinking this is a significant shunt.
Exactly. You need to start actively looking for a collapsed lung lobe, or in some cases, a hole in the heart, an intracardiac shunt.
Okay, this brings us perfectly to Part D, dead space, another absolutely essential topic. We've thrown the term around a lot, but we need to define it rigorously for the exam now.
Okay, the definition. Dead space is the volume of inspired gas that does not take part in gas exchange. It's wasted air, and you must classify it for the examiner. There's a hierarchy. First, anatomical dead space. Second, alveolar dead space. And third, the one that encompasses both, physiological dead space.
Which one of those three keeps the anesthetist awake at night?
Physiological dead space, without a doubt, because that's the sum of the other two. It's the total amount of wasted ventilation, and it's the one we are constantly altering, for better or worse, with our ventilators and circuits.
Let's start with the first one then. Anatomical dead space.
This is just the plumbing. It's the volume of the conducting airways. The nose, the pharynx, the trachea, the bronchi, all the way down to the terminal bronchioles. No gas exchange happens here. It's just a conduit to get air to the business end of the lungs.
And what's the normal value for that?
Miller and Morgan give a good rule of thumb. It's approximately 2 millibars per kilogram of ideal body weight. So in an average adult, that's about 150 millibars. An interesting little tidbit is that it's roughly equal to your weight in pounds.
Can this volume change?
It can. The size of the person, their age, their posture all have an effect. If you extend the neck, you stretch the trachea and increase it slightly. But the big one for us, the one we directly influence, is apparatus dead space.
This is all the gear we attach to the patient's airway.
Exactly. The anesthesia textbooks are very specific here. Apparatus dead space is the volume of the breathing system from the patient's end of the circuit right up to the point where fresh and expired gas mix. This includes the face mask, the catheter mount, and especially those HME filters, the heat and moisture exchangers. They all add dead space.
Why does this matter so much clinically?
Well, in a 70-kilo adult, adding another 50 milliliters of dead space with a filter is annoying but probably manageable. But in a pediatric patient, in a small baby, it can be absolutely fatal. If a baby's entire tidal volume is only, say, 50 milliliters, and your HME filter and catheter mount add up to 30 milliliters of dead space, they're just rebreathing their own CO2 over and over again. They get almost no fresh gas.
That's a terrifying thought. What about a tracheostomy? How does that affect it?
A tracheostomy decreases anatomical bed space, and quite significantly. You're bypassing the entire upper airway, the nose, the mouth, the pharynx. You're cutting out about 70 to 100 milliliters of useless tubing. This is why it can dramatically reduce the work of breathing for a patient.
Okay, now for the second type, alveolar dead space. That's the pathological one, right?
This is the pathological one. This is high VQ taken to its absolute extreme. The definition is alveoli that are ventilated but have absolutely no perfusion. VQ equals infinity. The causes, well, we've mentioned them. Pulmonary embolism is the textbook classic. But in our world, in anesthesia, you have to think about severe hypotension, low cardiac output, or high alveolar pressure from our ventilator.
It's that West Zone 1 concept again.
It always comes back to the West zones. If the alveolar pressure becomes greater than the arterial pressure in the capillary, the vessel just collapses. The air goes in, it fills the alveolus, but it does nothing. It's completely wasted work of breathing.
And that brings us to the third and final type, physiological dead space.
This is simply the sum of the first two, anatomical plus alveolar. This is the true total measure of ventilatory inefficiency in the lung, and you calculate it with the Bohr equation. This is absolute exam gold. You have to know it.
Okay, lay the equation on me.
The modified Bohr equation is VD over VT equals PACO2 minus PICO2, all divided by PACO2.
Let's break that down. VD over VT is the dead space fraction of the tidal volume.
Correct. And PACO2 is the partial pressure of carbon dioxide in the arterial blood, which you get from an ABG. PICO2 is the mixed expired carbon dioxide from the collected expired gas.
So artery minus expired, all divided by artery. What's the concept behind that?
Conceptually, it's asking a simple question. How much CO2 was in the blood and how much of it actually managed to get out into the breath? If there's a big difference between the arterial CO2 and the expired CO2, it means a lot of air must have gone in and come back out without ever picking up any CO2 from the blood. That air is dead space.
What's a normal ratio for this, the VD-VT?
In a healthy young person, it's about 0.2 to 0.35. So roughly 20 to 35% of every single breath is wasted.
And the exam trap here.
The trap is not realizing how this changes with disease. In lung diseases like COPD or ARDS, this ratio shoots up dramatically. In severe ARDS, it can be 0.6, even 0.7. Now think about that. If 70% of every breath you take is dead space, you have to breathe like a marathon runner at rest just to clear the normal amount of CO2 your body produces. This is precisely why these patients get exhausted and fail weaning trials.
So how do we actually measure all this in the real world, in the clinic?
Well, for pure anatomical dead space, the classic method is Fowler's method. That's the single breath nitrogen washout test. It's a lab technique, not something we do in the OT. It physically measures the volume of the conducting airways. For physiological dead space, the gold standard is the Bohr equation.
But practically in the operating theater, we're not doing that calculation minute by minute. We use capnography.
We use a clinical surrogate, yes. A very useful one. We look at the gap, the gradient, between the PACO2 on the blood gas and the end tidal CO2 on our monitor. Normally, that gradient should be small, maybe 2 to 5 millimole Hg. The blood CO2 is always a little bit higher than the breath CO2. But if that gap widens, let's say the blood gas CO2 is 50, but your monitor is only reading 30, you have a 20 millimole Hg gradient. That screams increased dead space.
And at that point, you have to start looking for a cause, like a PE or sudden severe hypotension.
Exactly. It's a huge diagnostic clue.
Okay, let's move to Part E, integration and clinical application. We need to tie VQ mismatch and dead space together neatly for the examiner.
The best way to think of them is as two sides of the same coin. The coin is impaired gas exchange efficiency. The high VQ end of the mismatch spectrum is what contributes to alveolar dead space, and the low VQ end of the mismatch spectrum is what contributes to shunt. Both of them result in the patient having to work harder, breathe more to maintain normal blood gases.
Let's talk about the effect of anesthesia specifically. We've touched on this, but let's formalize it for an exam answer. You said general anesthesia does three main things.
That's right. First, GA consistently reduces the functional residual capacity, or FRC. That's the amount of air left in the lungs at the end of a normal breath. Second, it causes a cephalid displacement of the diaphragm. Especially after you give muscle relaxants, the diaphragm loses its tone, and the pressure from the abdominal contents pushes it up into the chest. The result of both of these things is that the bottom of the lung gets squashed. You get basal atelectasis. This creates shunt.
And the muscle relaxation itself adds to this problem.
Yes, it does. Morgan's textbook points out that as FRC falls, it can drop below the patient's closing capacity. Closing capacity is the lung volume at which small airways in the dependent parts of the lung start to collapse. If your FRC is below that, then those airways are collapsing during normal tidal breathing. This happens massively in the elderly, the obese, and smokers under anesthesia.
Then on top of all that, we add specific postures and things like pneumoperitoneum.
Right. The absolute worst case scenario is the laparoscopic Trendelenburg position. You tip the patient head down, you fill their belly with CO2 gas. The diaphragm is pushed way, way up into the chest. The basal lung is completely compressed. Shunt increases dramatically.
Now contrast that with the lateral position lying on the side.
When you're awake, the dependent bottom lung is happy. It gets good ventilation and good perfusion. But once you're anesthetized, the weight of the abdomen pushes on that dependent part of the diaphragm. Ventilation becomes hard. But gravity is still sending all the blood there, so now you have a lung that is full of blood but very hard to ventilate. That's a low VQ problem.
So you're essentially creating a massive mismatch just by positioning.
A huge one. And that's why we have to use countermeasures like PEEP and a higher FiO2 to try and compensate for the problems we've created.
Speaking of the ICU and mechanical ventilation, how does all this relate to weaning a patient from the ventilator?
Well, in a critically ill patient, someone with ARDS, you often have a devastating double whammy. You have massive shunt from the collapsed, heavy, waterlogged lungs, and you have high dead space from microthrombi in the capillaries and damage to the lung tissue. We use PEEP to treat the shunt part of the problem, to try and pop those collapsed alveoli back open. But, and here's the provocative thought we need to consider, if you use too much PEEP, you can overdistend the remaining healthy alveoli. You can turn them into dead space.
So the PEEP can improve the shunt, but actually worsen the dead space.
It absolutely can. It's a constant balancing act. And for weaning, as we mentioned, a high dead space fraction of VDVT greater than 0.6 is a very strong predictor of failure. If that patient has to move 15 liters of air per minute just to keep their CO2 normal, because 60% of that effort is wasted, they are going to tire out and fail that TPEACE trial every time.
Okay, this is a lot to hold in our heads. Part F exam integration. We're in the home stretch. Let's do a rapid-fire comparison for the listener's mental whiteboard.
Let's do it. Fire away.
Okay, low VQ versus high VQ. Go.
Low VQ is shunt-like. It responds to oxygen. It primarily causes hypoxia. High VQ is dead space-like. It impairs CO2 clearance. It primarily causes hypercarbia.
Perfect. Shunt versus dead space.
Shunt is blood but no air. Dead space is air but no blood.
And the three types of dead space.
Anatomical is just the airways, the plumbing. Alveolar is the bad, non-perfused alveoli. And physiological is the sum of both. It's the total waste.
Excellent. Now for the really tricky part. Common exam questions and Viva traps. We mentioned the oxygen challenge. Let's role play it. You're the examiner.
Okay. Candidate, you've intubated your patient. You have them on 100% oxygen, but their saturation is stubbornly stuck at 88%. What is your primary diagnosis?
And the answer I need to give is?
The answer is shunt. A significant shunt. You should say something like, the failure to respond to 100% IO2 strongly suggests a significant shunt, likely from a cause like massive lobar collapse or potentially an intracardiac shunt. Simple VQ mismatch should have corrected by now.
Got it. What's the mask trap?
The examiner asks, does putting a simple face mask on the patient increase their dead space?
And the answer is yes.
The answer is yes. It increases the apparatus dead space, which in turn increases the physiological dead space and reduces the patient's effective alveolar ventilation. Showed them, the chain of consequence.
And finally, the trap in explaining physiological dead space.
Don't just say, it's the non-perfused alveoli. That's an incomplete answer. That's only alveolar dead space. You must be precise. You have to say physiological dead space is the sum of the anatomical dead space plus the alveolar dead space, which is comprised of alveoli with a VQ ratio significantly greater than 1 up to infinity.
Okay, diagrams. If I have a piece of paper and a pen in the Viva, what should I be ready to draw?
Two diagrams are your best friends here. First, the VQ scattergram from West's textbook. You draw the bell curve for a normal lung, low VQ on the left, high VQ on the right. Then you show how anesthesia widens that curve, creating more scatter, and adds a distinct shunt hump on the far left. Second, the three-compartment model from Miller. This is so simple and so effective, you just draw 3 alveoli side by side. Alveolus A gets ventilation and perfusion, that's normal. Alveolus B gets ventilation but NO perfusion, label it dead space. Alveolus C gets NO ventilation but does get perfusion, label it shunt. That simple drawing explains 90% of the marks for physiology.
Let's wrap all of this up with a final summary and exam conclusion. Give me the perfect elevator pitch for the examiner to end my long-form answer.
Okay, here is your 1-minute high-scoring concluding statement. In summary, ventilation-perfusion matching is the cornerstone of efficient gas exchange, with an ideal global ratio of 0.8. However, gravity creates significant regional differences in the upright lung, with the apex being dead space-like and the base being shunt-like. The induction of anesthesia consistently worsens this matching by reducing FRC, causing atelectasis, which increases shunt, and inducing zone 1 conditions via positive pressure ventilation, which increases dead space. Clinically, we monitor these critical derangements via the AA gradient, the patient's response to FiO2, and the PaCO2 to end-tidal CO2 gradient.
Wow, that's the 20-mark answer right there.
And the final take-home for you, for your practice. Understanding VQ mismatch isn't just for the exam. It is the fundamental framework you must use for troubleshooting the hypoxic patient in the operating theater. When that SAT probe starts beeping, you aren't just checking the connection. In your head, you are solving a VQ equation.
That's a fantastic way to put it. So for everyone listening, your homework tonight is to practice drawing the West Zone diagrams and writing out the shunt equation. Don't just look at them in the book, draw them out until you can do it on a napkin from memory.
My last piece of advice. In the Viva, when you're nervous, definitions are your shield. Stick to the standard, textbook definitions, bore, shunt, West Zones. Get those easy marks on the board before you get creative with your explanations.
And a final provocative thought to leave you with, building on what we discussed, we all reflexively reach for the PEEP dial to treat hypoxia. But at what point does your PEEP stop recruiting collapsed alveoli and start creating dead space by compressing healthy capillaries? When does the cure for your hypoxia become the cause of your hypercarbia? Something to ponder during your next ICU rotation. Thanks for diving deep with us. Good luck with the prep.
Good luck. Go ace it.